at home, you're going to have home health. You're going to have your physician to follow up with, his PCP, primary care physician, and his neuro physician, and maybe even a pulmonologist. Okay, and then of course the ENT, the surgeon ENT is the guy that's doing the surgery, placing the trach in. Where was I at? So cleaning the stoma is very important. That's done daily, if not more than once, maybe up to 2 to 3 times a day. But mind you, you're only limited on the saline, amount of saline, and you get 30 of these trach care kits a month. You get 10 of these a month, and then you get 30 of these in a box of saline. There's like, this will be a box of 15 ml at 48, so you have about a total of 750 mLs of this, which, I mean, if you're using this 3 or 4 of these a day, you're gonna run out pretty quickly. You run out in a couple of weeks. Yeah.
So you're loosening the tie every 6 hours just to check, or what?
Yeah, well, you'll notice it probably in his first couple of days at home that he has a lot of secretions, or a lot of a lot of drainage. So then you have to do it more frequently. Okay, I mean, you just can't let it go. You have to change this. Okay, you can maybe do 1 to save, or you can do 2. This one's 3 actually. It's 2, and these are they're pretty thick. These are absorbent. These are the absorbent type. This is more for like cleaning. This stuff here.
So what you have, that comes in the trach care kit or not?
No, these are separate.
They're separate.
They come in a box. Yeah.
You said how many per month of those?
90, but you'll get 100. You get 100. A box of 2 boxes of 50. And then the trach tube itself that's in him, whatever trach tube has to be changed. Medicare guidelines is every 3 months. Some patients can go up to 4. I've seen patients go up to 5 or 6, but usually the first trach change is done by the surgeon, but by that time you have to make an appointment well ahead of time to have him go back to outpatient just to have a trach change, and they'll do it, and you can set appointments for it. They may even do a bronchoscopy just to check his lungs if you have the right physician doing it. But I do trach changes too. So after the first trach change, I can do, with an order prescription, I can do the trach change, and that's like pulling the whole thing out and putting a brand new one back in. And it's not a procedure for the faint of heart, because you're actually pulling something out that's a tube like this, and it's going to be, it's going to be yucky. It's going to have all kinds of stains here, and then you have to put the other one back in, and you always have to make sure that it goes back in, or else you have a smaller size just in case it doesn't go back in correctly. And that's another discussion. So
Do you usually do a trach change within how long?
3 to 4 months.
Okay.
Yeah.
But he's seen people go up to 6.
Not my recommendation, but they do it just because they don't want the hassle of being changed every 3 or 4 months. Sometimes some of these patients, it's very painful, so they take medication for it. They take Dilaudid or morphine or anything, hydrocodone, and an anti-anxiety with it, because they get really anxious and fearful of that trach change. So they'll take medication, and basically they'll be well medicated by the time I arrive, and it becomes actually easier because they're not fighting. If they tense up like this is gonna spasm, and if you pull it out and that thing just, I've seen it where they're coughing and that hole is moving around inside. So you got to get it just right.
Moving target.
Yeah, it's a moving target, basically. Yeah. So we won't have to worry about that for like 3 to 4 months. Okay, and then you could have the first one done in the hospital, outpatient physicians. And if you want to continue with that, you can do outpatient every 3 to 4 months. Okay. So make sure you use this. Remember I said to go in and wipe this all down underneath and try to go 360, okay? And I did talk about that granuloma, but it may not happen for another 6 months to a year or even later. But just make sure you clean that stoma every day, sometimes twice a day, and then change the dressing. Of course, we'll have that like this. You gotta stick this underneath. It's really hard to do this when I only have one hand to do this. And my other hand is the trach. And
I'm sorry.
don't always keep your mind on this too. Be mindful of this wherever it's going, and just make sure you can see it. Go ahead. It's your question.
So you were saying something about home health doesn't cover this, but then you said that Medicare, it.
No.
No, Medicare doesn't cover.
Medicare does not pay my company or DME
Oh, I see.
for this. Like if we build it to them,
Okay,
they will deny it because he's on a home health episode.
but for what we need to know, we're getting a certain amount of the dressing and
Yeah.
the care kits and
Yeah.
everything per
Yeah.
month to use. Okay.
Yeah. You'll have that list. I'll give you a list.
Yeah.
Are you saying they need to buy those because they're not covered? Is that what you're saying?
It could be he buys it, or home health could contract with us as a letter of agreement. They will pay for it.
Yeah.
We don't give it out for free. Somebody has to be accounted for. Somebody has to pay for it. But I have a lot of, I'll leave it to that.
Yeah.
I mean, I could always get extra stuff for you guys, for him. So, any questions with the trach care?
Yeah.
You could go online and watch YouTube trach care, how to do trach care on a trach patient with on a ventilator and cuffed trach.
Okay. Just to go over daily trach care, what do we do? I know you've gone over it, just the things we do every day.
Well, the things that you do every day is change this dressing, sometimes more than once a day, and then clean the stoma with this trach care kit with normal saline and hydrogen peroxide, and you use these gauze to clean the stoma and the Q-tips. And then if you're running out of inner cannulas, they have this inner cannula brush, quill brush, that you can actually clean inner cannulas with. I'll give you an example. You remove the old inner cannula, you put it in a box like that, and it's filled with hydrogen peroxide, just straight hydrogen peroxide. It's gonna fizzle up. You put the new one in, and then you just grab this, and then just with the hydrogen peroxide, you're gonna brush it, make sure there's no guck, no mucus, dry mucus inside there, and then you can do the outside too if you have to, and then do a final rinse with distilled water, and then flick the distilled water and use one of these gauzes to dry it up. Make sure it's in a clean environment, and you can put this in a Ziploc, a clean Ziploc, and just label it, put the date, and then you reuse it once. But it does say, do not clean or reuse.
Okay, so I didn't just take it out
But
if we haven't touched.
yeah, but if this is your last one and you really need to change it, well, you can reuse this. I've seen many people have reused this in case they have to, if they're all out or there's nothing in inventory. Sometimes with the new trachs, we are low on inventory. The supplier only gives us a certain amount, and we have a lot of trach patients out there, and sometimes patients will have to wait sometimes up to between a week to get the inner cannulas, and I just tell them, when they're in their last 5, just alternate that last 5 and stretch it out to 10 days. You can have 5 of these and stretch it out to 10 days if you alternate. Okay, I don't advise you to do that, but if you had to, you can. You could try finding them online if we're low on inventory. It's just the way the medical equipment has been lately. It's like all of a sudden this company, Covidian, who makes the Shiley brand, they decided to get rid of this DCT, all the DCT trach tubes, and change it to CN85 or CN70, 80. It's a different number because I think they were low on this certain plastic or whatever, vinyl or whatever this is. So now it's completely different. The trach tubes are completely different. So if you see this cuff here, their cuff is more like, the new cuffs are the teardrop shape. This is more like a cylinder shape. Theirs is like teardrop. It's wider in the top and narrower at the bottom, kind of like that, like an acorn. I don't know why they did it. Maybe it's because of this type of material that they're low on, could be. Because the Red Robins that Bard used to make were the best suction catheters ever made specifically for ALS patients, because you can go down there and suction them, and it's so soft of a red rubber catheter. So this is not rubber. This is also like plastic. See, it's hard. We used to use the Red Robin from Bard. They were the softest, and they were larger than this, and you can get a lot of secretions out. Oh, by the way, he can continue using the cough assist when vented and trached. We use adapters to connect it, similar to this, and then we can still use the same line. We just change out with everything new with the hoses and the filters, and then he can, if he has a lot of secretions, let's say you don't want to suction him too frequently because you're causing too much irritation, or you see blood coming up with the suction, maybe just hold back on the suctioning and use the cough assist instead. If he starts sounding congested, you'll hear it. You can even feel it on his chest, the airway congestion, and you can even oftentimes hear it. It'll sound like something coarse, like that. Well, instead of suctioning him and doing it the fast and easy way of suctioning, do the cough assist therapy, and then it'll pull the mucus out after about maybe the 5th to the 10th cycle of breaths. So you can continue to use the cough assist to, get rid of the secretions from his lungs. So that's secondary to this. So this is always primary, suctioning is primary, but you can use the cough assist as needed. I would still continue to use it at least twice a day, if not 3 times a day,
Okay.
after he's trached. And it's a great way of getting secretions out without having to traumatize it with the suctioning. It's like, I don't know, when I was in respiratory school, they made us suction each other through the nose. And I only was able to go that far, and I said, I can't take it anymore. And it just causes so much, I mean, I think I bled and I was crying, my tears. And so that's being suctioned through the nose, though. We do that on babies quite frequently in the hospital. Babies that have pneumonia, bronchitis, or bronchiolitis, sometimes asthma with reactive airways disease, and they're wheezing and they produce a lot of secretions. We have to suction babies through the nose. That's the only way to get the stuff out of their lungs. As adults, we try not to do it, but with ALS, that's why we have the cough assist. But there are some patients that require deeper suctioning before they're trached, and sometimes nasal airway deep suctioning can get the secretions out. Anyways, back to this. Where was I at?
So you said we clean the stoma, and then we
Redress. You change the dressing.
change the dressing.
Yeah, and then you also look at his this, and see if this needs to be changed as well.
Okay.
It's not every day that you have to change this, but it depends on if he's sweaty, if it looks a little,
Grimy.
dirty, or whatever. It doesn't look clean anymore. Just go ahead and change it, because
And we get 30 of these.
you get
right?
30 of these. Yeah.
Okay.
Yeah.
And then you change the inner cannula as well, right?
Yes.
So that's the other thing. you
Yeah.
do.
Inner cannula gets changed too. That's once a day.
Once a day.
Yeah.
Okay.
You don't want to do it twice a day, because then you're only allotted 30. So if you're going twice a day, then you have to buy the other 15.
Okay. So then what else do we need to do? Do we change the suction
This is,
Thank
I
you.
said this was twice a week.
twice a week?
Yeah.
Okay.
Don't worry, I will give you a paper that
Okay.
has your daily, your
Okay.
weekly, your bi-weekly, and your monthly.
Okay, yeah, that would be helpful.
Yeah.
So you said the red, the softer one is not available anymore?
They do make them, but they're not as nice as the Bard. The Bard was the manufacturer, the name of the manufacturer was Bard, B-A-R-D. They don't make them anymore. They stopped making them. Probably they ran out of that.
So the ones that were more for the ALS, like you said that they were soft, they were nicer.
Yeah, they're gone.
They're not available.
No. But they do make Red Robins, but they're red rubber. They call it red rubber, but they're just not as nice as the Bards.
This is the Bard.
This is a closed suction catheter. What I'm talking about is like a single-use suction where you actually it's not enclosed. It's a catheter that you have to hold like this, like that. It comes inside a package. So you probably won't ever have to use that single-use catheter, but I'll give him some just to have in case you wanna practice, you know, he might like to be suctioned that way. It might be more effective because you have full control of the catheter. As compared to this closed suction, you have limited control. You can only do this and maybe like that. Like that. But if you had it on your hand like this, then you actually have more control doing it like this with your fingertips and just going in and they're suctioning out.
So is it better to twist it while you're pulling
I don't
out,
know.
so to try to get more range?
Yeah, it's try, just twist it a little bit like that. If you watch, I'm just going like this. See that? So when you're pulling out, you're getting right and left as you're pulling out. So it's gonna take a bit of practice for you guys to get really good at it.
But it still goes the 5 count when you're pulling it out, but you're twisting at the same time?
Yeah. If you can handle longer than 5, that's okay. A lot of my patients go 10, 20 seconds during the whole duration of the suction off the ventilator. They're completely off the ventilator sometimes for up to 20, even 30 seconds. So
So
For him-
you have to take them off the ventilator to suction.
if you're using a single-use catheter,
Okay.
but if you're using a closed inline suction catheter, no, you're connected. It's a closed system.
Okay.
That's why it's called closed.
Gotcha.
And it's closed because of this plastic final.
Gotcha. Then.
Okay. All right. What else? Any more questions?
How would you compare the current secretion problem he has, because he gets worked on a lot for plugs?
Yeah. You're gonna still have some secretion problems on the upper airway because he still may produce, but it's gonna be less. It's gonna be a lot better compared to the way it is
The upper
now.
will be a lot better.
Yeah.
How does what he's experiencing now compared to what you predict?
Well,
for
it's
lower?
everybody's different, but for the most part, now that you'll have actually better access to get the secretions out with a trach tube.
Yeah, so it
Because
should be
you're
better.
closer to the lungs this way because it's right here instead of up here.
Yeah.
You're down here already, and you're only like 4 inches away to get into the right or left lung. It takes about that much, and then you're already pretty much in the airway right there. So
Wow.
yeah,
So you're actually pulling secretions out of the lung.
yeah. This is going directly into the trachea, and then it's basically a trachea all the way until about right above the clavicles, about that far above the clavicles. You have about that much space above the clavicles when the trachea stops, and then it becomes airway. It becomes the right main stem bronchus and the left main stem bronchus. And those bronchuses are your large upper airway, and that leads to the smaller airways to your right lung, and your lungs are subdivided by lobes, upper, middle, lower lobes. And you can't get to the very lowest lobe. because-
But you're cleaning right at that point, right at that intersection.
Yeah, you're cleaning at the intersection,
That's
and then
good.
when you have him cough, when it touches the carina, anything below the carina, he's coughing up. It's being pulled up, and maybe whatever cough he has left, because he's gonna go. It's not a strong cough, but it'll be just maybe enough to get the stuff out, and that's why I say continue with the cough assist, because that cough assist is actually a lot of air pressure to suck out that secretions and maybe pull it up closer to where it can be suctioned out.
Okay. Gotcha.
Yeah. So continue the cough assist, and I will train you guys on the cough assist when he comes home.
Okay.
Okay.
I don't have any more questions.
Is you said that this can irritate when it touches the carina, and
It causes a cough reflex.
sometimes there's blood even?
If he's being suctioned too often, and you're hitting that carina frequently, like this, it could burst a vessel, small vessel. Blood may appear.
And if that happens, then use the
Then you have to
conscious-
like slow down the suctioning or don't go as deep. And then I would advise put some saline in the refrigerator so it's cold, and then you want to instill before you suction. Because the cool saline always kind of soothes the airway, the irritation in the airway. Cold saline, at least refrigerator cold, not ice cold, but refrigerator cold.
Is that something you do routinely so that it doesn't irritate?
No, you would probably do the saline installation or lavage about every third or fourth suction session. And you definitely probably want to instill saline when you're doing a cough assist. Especially with the cough assist, because you're really pushing this in the lower airway with the inhale pressure, and then it's going to be pulled out with the saline, and the mucus will come out at the same time. Sometimes the saline will come out first.
So that's gonna be one of the daily things.
Yeah.
Looks like.
Yeah, it will be the daily things for sure.
And do we have a lot of saline, you said?
You get a box of saline, and they come. You get two choices: a box, 100 of 5 mLs, or 48 of 15 mLs. So obviously, 100 of 5 mLs is only 500 milliliters, and then 48 of the 15 is 750 mLs. So you get more if you take the 15 mLs. The only difference is when you open this up, you may still have a little bit left over, or at least maybe 3/4 over, and you want to just put it in a I'd say like a shot glass, a long shot glass, and then cover it with a Kleenex so it doesn't get dust on the tip. So it remains dust free or bacteria free. But then you can reuse it. Right.
I have one other question. Earlier, when you said we cleaned this the catheter,
Mm-hmm.
and then there was another method you said about pushing the saline.
Yeah, you just basically remove this and squirt the saline directly into the trach.
Oh, directly.
That's the other way, yeah, like 2 cc's directly in.
Then you
Then you
connect
put
it
the
back
vent,
and
then
then
you put the vent
suction.
back on, and the vent air will push the saline into his lungs, into his airways.
So he'll be off the vent for a few seconds when you.
Yeah, he can handle being
He
off
can
the
handle
vent.
it, okay.
Yeah, for a few seconds.
Mm.
Now, mind you, this is a whole new world for you guys, and especially for Dan. It takes time for him. He'll have pain here, probably for 3-5 days, and it'll still be sutured in place for up to 10 days. So you have to be sensitive to know that whatever you do working on the trach, you're gonna try to minimize pushing, pulling, turning. You gotta minimize all that.
Yeah.
And that's why
Yeah.
you have to. I know it's gonna be tough to do this, but I know that you can do it. It's just basically most important part is clearing his airway, and if that means he feels a little bit of your tremors, that's okay. It's better to get the secretions out. Okay, so you guys will get used to this, and if you want to take one of these home to practice, you're welcome to take one home to practice. Whoever wants one.
Yeah, we can leave a couple here too.
Yeah.
So okay, thank you.
Let me add this one here. Let me inflate the cuff. So he's gonna get one of these, but probably a 10 ml. Because you'll need to eventually inflate the cuff because it will leak air. Now this is a size 6 and that's a size 8.
Okay.
So an 8 will require about 10 mLs to fill up. Probably a 6 will require maybe 8 mLs.
Okay.
Can you tell me again, what is the tubing called? You said it's like a flex.
Omniflex.
Omniflex.
Yeah.
And that's that part, and then there's the catheter,
This is the closed inline suction catheter.
that's that part.
Yeah, this is that part right there.
That's that whole thing.
Yeah, that's the whole thing. That's the pieces that come with it. This is a separate piece here. It comes in its own package.
Omniflex attaches to the outer cannula.
Yeah, some people will bypass it and connect it to here, but it's they don't have much
Yeah.
drag or like turn them. There's not enough space. So that's why we give the Omniflex.
Yeah.
So you have a little bit more space to be flexible to turn
Okay.
like that. And then like you want to make sure that this isn't pulling, so we kind of put something underneath, like
So
a
towel.
like a little small towel, face towel, just to keep it like that. So he'll be in pain for the first, week. He may require, I don't know if he's a pretty tough guy, so he maybe just anesthesia from the surgery. He may not require any medications after that. Maybe just Tylenol. But this will be sore. It's a surgery, so it's going to be sore, just like Dan, you were sore with your stomach with your peg, right? When they put the G tube in. Were you sore for a couple of days? Yeah? No? 3 days? 2 days? Oh, okay. One day.
Half a day.
Half a day. Half a day. Yeah. It hurt? Was it like somebody pinching you? Right there in the stomach? Alright, so it's gonna hurt in your neck for maybe more than half a day.
Like
Basically the
someone's
same
pinching
thing.
your neck.
Yeah, someone's pinching your neck. That's painful. He'll be able to continue his breathing treatments too. We
Okay.
will add what's called a Neb T valve.
Yeah, I think I know. You did that
It's
once.
the blue one.
Yeah.
Yeah.
you did that
I
once.
think I had one in there.
You had one for this.
So he'll have a Neb T valve on his ventilator circuit as well. And you guys will be changing the whole ventilator circuit once a month. That is up to 30 days, rated 30 days for the vent circuit. The bacteria filter could probably be once a week.
Okay.
And then the rest is the Omniflex and the closed suction catheter. And then the dressings.
So the same vents, right? The
Same
exact
vents, yeah.
Same vents, okay.
Yeah, he'll use the same vents. In the hospital though, I might bring an Evo for training.
Okay.
Because it depends on the hospital. They probably want the Evo for training purposes, but he can continue to use these vents at home. I'll probably give him all brand new filters, like the back of these filters, the back here.
Those foam.
You guys are,
Yeah.
this one's missing one.
Is it?
Yep,
Yep.
missing a filter.
I don't know.
Let me see if I have one in the car. But I'll get him one. I'm gonna provide him all new filters.
Yeah. So when he stands up to go into the bathroom, we just connect him to that.
And carry it.
Yeah, and we'll put it on the walker, so it's
Put it
easier
on
for him.
the walker.
Yeah. All right, you can
We can stop. Okay.
stop. I don't know. That's gonna